Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Thanks so much for joining us. Today is Tuesday, July 5th, 2022. We started a little bit later than usual today, but for a good reason. The mayor and others were doing an event related to the fact that we have seen some bipartisan progress in the Senate on some basic gun control. Obviously, this is something that we're very interested in at the Health Department. There's also a proposal for some additional funding related to mental health. So there was an event streaming on the channel related to that. So, although we're joining you a little later than usual, again, for a reason we care about. As you can see, we have two guests today. I'm going to introduce them briefly, and they're both here because the main thing we've been getting a lot of questions about is monkeypox, or what we're now calling Mpv, monkeypox virus. Mpv is the term we're generally using. So, as always, you can get your COVID questions answered, but we also brought two of the experts from the Health Department who can help answer your many questions about Mpv. So happy to introduce, this is Dr. Jana Cairns. She is one of our medical directors in the Communicable Disease and the Disease Control Bureau. And then Massimo Pacilli, who is one of the deputy commissioners, also in the Disease Control Bureau. So can you just introduce yourselves a little bit about your background and what you're working on now?
Thanks for having me. As Dr. already said, my name is Jana Cairns, and I'm actually a veterinarian by training. I've been at the Health Department now for a few years, and I work primarily on zoonotic diseases, which are diseases that spread typically from animals to people. And so that's how I originally became involved in this Mpv investigation, because it's typically spread from things like rodents to people. I also was very involved in the COVID work as well, so primarily working with workplaces and also on outbreaks in community settings.
Thank you. And I'm Massimo Pacilli. As Dr. Arwady was saying, I'm the Deputy Commissioner for Disease Control, and I really support the epidemiology and laboratory capacity across the Bureau, and all of the work that's done in infectious diseases, like Dr. Cairns was highlighting, zoonotic diseases, as well as other communicable diseases and vaccine-preventable diseases, and the work that's also done in some special settings, like healthcare settings, youth settings, homeless, correctional settings. And I actually had, during COVID, I was very much sort of involved in the laboratory diagnostic piece. I have a background in laboratory science, and I'm sort of here to reflect the work that the department is doing related to our current Mpv response.
Absolutely. So great. Thanks for being here. As always, you can put your questions for any of us directly into the box below, or you can use the hashtag AskDrArwady on either Facebook or Twitter. So we will start out, as always, with some COVID updates, and then we'll move directly into Mpv. So let's go ahead and pull up the dashboard, chi.gov/COVID-. And we do continue to update this really Monday through Friday, unless it's a holiday like yesterday. And if you take a look, what you see is we're seeing a slight increase in cases, averaging 745 cases per day, up about 10% from a week ago. A lot of that is in the context of seeing more of this BA.4/5 subvariant, which is the most contagious variant yet of Omicron and of COVID. But in that context, we haven't seen an increase in severe outcomes. You see we're averaging about 25 Chicagoans being hospitalized a day, down from 28, still much less than one death per day, which is also down. And you can see we've had a little over 7,700 Chicagoans die of COVID-19 at this point. Vaccinations are up. Some of that is because of the little ones getting vaccinated for the first time. And you can see that 77% of Chicagoans have had at least a first dose of vaccine. And if you look at that cumulative vaccines administered, as of our July 1st update, we passed the 5 million vaccine threshold. So that means Chicagoans have received more than 5 million COVID vaccines. They've been safe, they've been effective, and they've been huge in terms of turning cases not into hospitalizations and deaths. You can see testing is now pretty stable, down from where it was since we're out of school. And positivity is actually stable from last last week as well. And remember, positivity means a lot less than it used to, given that people are, for the most part, testing at home, which is great, and that while the schools are not in session, we have much less formal testing happening. So all to say, things remain in a relatively stable place, although still a lot of COVID and still really at that higher risk level. So let me move into some slides here just to talk a little more about that. And all of this is available. We post it and it's available on the dashboard. So first of all, remember, every week the U.S. CDC updates the counties and report that whether they're high in orange, yellow in medium, or green in low. What is the COVID community level? And more than half of U.S. counties at this point are either high or medium, and Cook County does continue at the high level as of the June 30 update. We'll see. I was actually guessing that we would move back down to medium, but it hasn't happened just yet. We're still right on that borderline. I do expect shortly we probably will come back down, but the BA.4/5, how quickly that's been coming, has kept us right on that borderline. And if we look at the details of this, remember, we get this question a lot. How are those community levels calculated? The CDC looks at new cases. The goal is to be less than 200 per 100,000 over a week, and then new COVID admissions, and the goal is to be less than 10 per 100,000 in a week, as well as staffed, like what percentage of your hospital beds are taken up with COVID, and the goal there is to be less than 10%. So you can see that if we were just limiting it to the city of Chicago, people who live in Chicago, both of those metrics are actually below where we would want to be. But Chicago is part of Cook County. Our data is included in that, and they look at this data at a regional level, especially for hospitalizations. And so you can see Cook County overall is at 207, just over that 200 mark, and the hospitalizations are at 10.7, just over that 10 mark. So we need one of those to drop back below the goal to move back to medium level, and we need both of them to drop back down to be at the low level. So again, we remain on that borderline, and I do think we'll probably be coming back down soon. But in the meantime, please be wearing your mask indoors, and please, please, please make sure you are up to date, including boosters with vaccine. If we look at some of the additional COVID indicators, people have been quite interested in this. Behind the scenes, and actually the folks who are here with me today are part of the team that updates this. So if you've got questions, these are good things to ask about. If we look, for example, at what percentage of people coming to the emergency department in Chicago turn out to have COVID, we're at a low concern level for that still. If we look at our wastewater monitoring, we're at a medium concern for that. If we look at what we're seeing with variants here, with that BA.4/5, we're at a medium risk there. And then finally, if we're looking at recent outbreaks in senior, youth, and behavioral settings, we're at a low risk there. So again, no major concerns, new concerns in Chicago, although certainly a lot of COVID. This was just updated today, so this is the most up-to-date information. You can see through July 2nd. Remember, each of these vertical lines is a week, so it goes back to early April, and then the vertical bar on the right is the week ending July 2nd. In green there are the BA.4, BA.5, and you see between them, BA.5 is about 55%, BA.4 is another 17%, and so just of every few weeks, we've been seeing these new subvariants emerge and outcompete the older ones, and that is what is keeping numbers high still in Chicago. One of the reasons why we expect there will be an updated COVID vaccine in the fall, probably late October, November, is that it's important at this point to have a vaccine that's been updated to be more protective against Omicron, for example, because we're seeing a lot of breakthrough infections, people who have been vaccinated, or people who had COVID before. We're seeing very, very little continued protection from, folks who if you had COVID 6 months ago, 9 months ago, it seems to have almost no protection against Omicron. So having an updated vaccine will help with hopefully cutting down some of the continued transmission of COVID. But again, the severe illness remains relatively low. If you look across the U.S., you see those same green colors are the majority now across the whole country, and that's what's reflecting some of this. So if you look at our vaccine operations, as of the end of June, we are up to 4.9 million doses. July 1st marked our over 5 million threshold. But if you just look here, and we post this online. If you don't follow us on social, I encourage you to follow us. But it gives you a sense of all of the various ways in which we continue to work, CDPH continues to work on vaccine operations. So you can see that, for example, there have been nearly 700 completed mobile events. There have been 38,000 vaccines through our at-home program, which continues to go really, really strongly. Our family vaccination series, which are the ones we do in city colleges, are going really well. We've done more than $3 million of incentives with vaccination cards in total. We've been operating our call center, which we really stood up with vaccine, more than a year now. We've handled more than 500,000 calls, so huge thanks. 809 call takers who part of our response corps have been really amazing. More than 6.5 million doses have been through our medical providers here. 758, and those are going to be your doctors, your pharmacies, your urgent cares. 758 providers across Chicago giving COVID vaccines, and then more to come. So just, behind the scenes, lots and lots of work happening. In no way have we stopped vaccinating. And, as I mentioned already, this milestone is one we were really excited to hit. I wanted to quickly mention that vaccinations for children under 5 are going very well. We've been seeing some good uptake, no concerns about safety. We've had no adverse events at this point reported to us here in Chicago. A reminder that the doses for young children are much smaller. So for example, if your child's getting a Pfizer dose and they're under 5, they're only getting 1/10 of the dose of what an adult would get. So we're not really seeing problems with side effects. Things have been going very, very well. And our family COVID vaccine clinics also have had really nice uptake. I wasn't sure if we'd see a lot of folks coming, but we have hundreds each weekend. And so this coming weekend, we'll be at Truman College and Malcolm X College on Saturday, 9 to 2. You can register in advance, but you don't have to. And we've got Pfizer and Moderna for ages 6 months through 4 years, and then Pfizer first dose, second dose, boosters, all of the above for everybody age 5 and over. So would love to have anybody come in. It's all free of charge, and come up to date that way. Lots of questions still about boosters. So once again, let me just remind you, very top line, unless you started getting vaccinated in the year 2022, you should have had at least 3 COVID vaccines. So if you started getting vaccinated in 2020 or especially 2021, you should have had 3 doses. If you started with Pfizer or Moderna, you would have had those first 2 and then 1 booster. If you started with J&J, you actually should have had 2 boosters by now. So everybody over the age of 5 should have had 3 vaccines unless they just started getting vaccinated. And then for anybody who's over 50 or has a moderate or severe immunocompromise, really you should have had 4 vaccines by now, a second booster dose. And so there's more detail online, but everybody over the age of 5 should have had that booster. And then again, people over 50 and then anybody over 12 with severe immunocompromise should have had the second booster. Another really easy way is getting vaccinated at home. Kids under 5 are eligible. We've got Pfizer and Moderna for the little ones. We'll set you up with an appointment Saturday, Sunday, Monday, Tuesday, 8 to 6:30. We've seen some churches choosing to set up at home, quote unquote, meaning at church appointments and vaccinating, 10 members of the church. We love doing that. So would like nothing more than to continue to see people. And you're welcome to get a booster. That was a good question. Yes, you can get a booster free of charge through this program. And then as always, you can go to chai.gov/COVID or call 312-746-4835. I'm now going to hand it over first to Dr. Janet Cairns, one of the medical directors at CDPH, to start with the Mpv, monkeypox virus update.
Sure, thank you. So first, I just wanted to start with some basics about Mpv. So this is just a graphic that we've shown even on social media and elsewhere on our website. So just also wanted to let people know that they can go to our website as well. So chi.gov/monkeypox or chicago.gov/monkeypox to get more information. And then this actually goes into a little bit of the detail that was on the previous slide. So Mpv is a viral infection, so a virus, just like, COVID-19 is caused by a virus. Typically, in terms of symptoms, what we see, at least traditionally what we have seen, is that usually MPV starts with a flu-like illness. So think, a headache, fever, fatigue, chills. Some people can get swollen lymph nodes or glands like under your neck or in other areas of the body. And then usually what has happened in the past is that then a rash forms, and that rash can look like pimples or blisters. What we've seen currently is that not everybody necessarily develops that flu-like illness. So some people only wind up having a rash. And we've also seen that rash can be limited to certain locations. So for example, in the genital region is a common location that we've seen. Spread, different from COVID, most commonly occurs by skin-to-skin contact. So that means that you have actually touched somebody else's rash or sores or some type of body fluids. The body fluids or sores can also contaminate different types of items like clothing or linens, and then can potentially affect you. And then kind of lastly, respiratory secretions. So that is kind of those respiratory droplets that can come out with intimate contact, such as kissing, cuddling, or sex, can also be a source of infection. But unlike COVID, this requires typically prolonged face-to-face contact. So, whereas with COVID, we think you have to be within 6 feet of someone for 15 minutes. With MPV, it's within 6 feet of someone for 3 hours. So really quite a big difference between those two. And then finally, anyone can be infected with MPV. So regardless of who you are, if you have contact with somebody's source, for example, then you are at risk of being infected with MPV. And then I wanted to just give an update on kind of where we are with MPV in Chicago right now. So as of yesterday, a total of 73 Chicagoans have been diagnosed with MPV. The majority of them, although not all of them, of those infections have been among those who are gay, bisexual, same gender loving men who have sex with men or MSM. And what we have seen is that spread really is occurring through tight-knit social networks. So people who have intimate contact with one another. And really, I want to highlight here that overall, the risk of MPV does remain low for the general public. But if you are actually having symptoms, so a new or unexplained rash, then it is really important to see your healthcare provider. So if you have a healthcare provider, you can call them and tell them that you're potentially worried about MPV and see them. You can also call, our COVID call line, which is 312-746-4835. Those call takers have many skills, and one of them is that they can also help connect you to care if you don't have a healthcare provider, and that goes for MPV or for COVID. And then if you're seeing your healthcare provider and you're really concerned about MPV, just don't hesitate to advocate for yourself. So feel free to remind your provider that MPV is in the community in Chicago. And then also, if you're not feeling well, regardless of kind of what type of not feeling well you're thinking, whether it's you think you might have COVID, whether you think you might have MPV, it's always a good idea to stay home if you're feeling sick, especially until you've actually been checked out by a healthcare provider. And as part of that, avoid sex or being intimate with anyone until you've been seen. And then I'm going to start, and then I'll turn it over to Massimo. But so I just wanted to say that there is effective treatment and vaccines against MPV. MPV, unlike COVID, is not a new disease. It's something that's been around for decades, and the advantage of that is that we already have both treatment that we can potentially use to treat people who've been diagnosed, and then also vaccines to help prevent people from developing MPV. And then I'll turn it over to you.
Great. And again, Massimo Picilli, Deputy Commissioner for Disease Control. So just like Dr. Cairns was reminding us, monkeypox of MPV is a disease that we've known for some time. And so the fact that we know how it spreads, we know how to identify it, we have effective diagnostics for it, and then we have treatment and vaccine. And so we have all of these tools to respond to this outbreak of MPV that is presenting in our communities. So related to vaccine, we think of this as sort of a really important intervention along with isolation and adherence to all of the things around prevention and what we can do both to avoid the exposure and then manage the symptoms if somebody is infected, is to deploy this available vaccine that is a 2-shot under your skin, 28 days apart. It's called Genius, is the name that it runs with here in the US. And this vaccine can do a couple of things. So it can be both used as what we call post-exposure prophylaxis. So the health department and others in the our partners in clinical settings get information from those who are being evaluated or being diagnosed with MPV to understand the potential source of exposures and those they might have been in contact with. And so in this context, this vaccine can be provided for someone who has had intimate contact for somebody who is diagnosed, or they are partners of somebody who is diagnosed with MPV. And so this is what you see on the left-hand side. And then because of what we're learning from our investigations and the fact that we want to ensure that we deploy this vaccine rapidly to prevent the onset of illness, is that we identified those who can benefit most by receiving the vaccine. And those are broadly, in the context of what we're observing thus far, gay, bisexual, and other cis or trans men who have sex with men, who either have had intimate or sexual contacts with other men in a social or sexual venue. They may have multiple or anonymous partners, or those who have given or received money or services in exchange for sex. And as a reminder, at this point, MPV vaccine is not recommended for the general public for much of what Dr. Cairns was talking about in terms of the risk for the general populations remain low. And when we think about vaccine in this context, this is an emerging disease, and we certainly, thankfully, had these tools on the shelf ready to go. And so the ability to deploy a vaccine for this purpose is incredibly valuable. But recognizing that at present, the amount of vaccine available is limited, is to allocate that vaccine where it can do the most good. And that is both among those who we know have been exposed to somebody with MPV, or those who may have been and we don't have it quite on record, or may be exposed in future. And that's what we're doing, both. We have been doing at the department since the initial cases identifying in May, and we're doing now in alignment with the strategy at the federal level. And certainly as more vaccine becomes available, that would expand perhaps. And we're doing much of this work with partners of those that engage with these populations that we know can reach again, those who can benefit most by doing some pop-up events, mobile outreach, all of these leverage in the right setting to give the vaccine to those who may need it most. And then as a summary of what the current response looks like is that we at the Chicago Department of Public Health really work with clinical providers to facilitate testing to identify MPV and provide treatment for those who may need it, those who may be at higher risk of developing a more severe illness. And then really doing that work of identifying the contacts and monitoring and providing this vaccination opportunities for those for whom it's indicated. And then really supporting everybody to experience reclaiming these parts of social life post-COVID pandemic, of importance to do so safely. And that looks both in terms of education and partnership with community-based organizations and organizers. And then this last piece that I was just highlighting, delivering vaccines directly to those who are highest risk for the exposure. And as a reminder, not broadly to the whole of the population. And then we have much of this content in our publicly available website. Here it is on the left side, chicago.gov/monkeypox. And there you'll find some of the content we were just talking about. There's some frequently asked questions and answers that may be sort of really in support of both clinical providers and all of us, all of the public. And then also some palm cards and posters that we hope partners can leverage and businesses and event organizer can sort of disseminate in the settings as they can inform their public and attendees. That's sort of a high-level summary. Yeah.
All right, great. So let me go ahead and turn to your questions. Feel free to put in MPV questions, COVID questions. I'm going to end the slideshow here. And just to sort of get us started here a little bit. Oh, good. Number of questions in already. So let's start with the basic one. What should I do if I think I might have monkeypox? And then I'll get into some of the other ones as we go from there.
Sure, yeah. I think the main message here, like we mentioned before, is you should talk to your healthcare provider. So first thing first, if you have a primary care provider, give them a call. Tell them that you suspect that you could have MPV, and then get yourself seen. I think along with that, if you don't have a healthcare provider, as I said before, you can call 312-746-4835, and we can potentially connect you with a healthcare provider. And then in the meantime, stay home. It's not the time to kind of be going out to other events if you think that you might be having, if you think that you might have MPV. So stay home if you're feeling sick until you can get yourself checked out. If you do have actual sores or a rash, then try to keep those areas covered, as they can potentially be contagious to other people. And then also it can be helpful to wear a mask around other people as well.
All right, sounds good. We're going to go back and forth between some of the COVID questions and some of the MPV questions. And you folks, they can answer the COVID questions too, so feel free to chime in. McGuire on Facebook says, why are you still hosting vaccination events at city colleges? It seems unnecessary, and that those who are truly motivated to get vaccinated will do so at a pharmacy or somewhere else. So, good question. We always look at the data, frankly, when we are making these kinds of decisions, and especially for the youngest children. What you'll find is some variability in terms of how young pharmacies will vaccinate. For COVID, there actually were some additional there were some requirements that were changed that will allow pharmacists and others to vaccinate down to the age of 3. But for kids under 3, unless you're at one of the actual minute clinics or other, more provider, not all pharmacies actually will vaccinate. And we've seen a number of pharmacies just decide, you know what, I don't want to vaccinate kids under 5. And so we have seen about 30% or so of our little ones get vaccinated in pharmacy settings. Our first recommendation is to go to your provider. So if you have a pediatrician, if you have a family practice doc, please go there, because they can make sure you're up to date on everything else and, check the other things to make sure your little one is doing well. But at city colleges, we're seeing hundreds of people turn out. So I think, we made this decision to actually do a series of 3 events, so that even for the little ones, if they were choosing to get Pfizer, you can do 1, 2, 3. But what's been really nice is, this last weekend I was looking at the data, and we were at Daly College and did somewhere in the vicinity of 100 or so vaccines, but we did many more vaccines for older people. We did boosters, we did first vaccines for 5 to 11-year-olds, which I love, in addition to the little ones. And then at Wright College, we did about 200 vaccines, and that was about 150 of them were for the little kids. But again, we really are seeing other people come in, and sometimes with a little one, but sometimes not. So while we're seeing hundreds of people choose to use these sites, we will absolutely continue to host them. I think they're also, people sometimes, they know city colleges, they know how to get there, they're public transit associated, they're very efficient, so you're not waiting. They know that you're not going to get charged, there's no barriers. So yeah, we're going to continue following it, but we have committed every Saturday all the way through early September, you will have the opportunity at either 1 or 2 of the city colleges of Chicago to get a vaccine. And we think it's a good thing to invest in. All right, let's get one of the Mpv ones here. Here's a good one. So how likely is it if I go to a gathering with thousands of people that I could get monkeypox?
You want me to take it?
We can go back and forth.
Yeah, I think the very short answer is unlikely, because the primary spread is really kind of close contact. So main form of spread, right, is really you have to have contact with somebody's sores or rash or body fluid. So even if you're in an area with a large number of people, it's really kind of that close, intimate contact. And so it would be very unlikely for it to spread. And then anything you want to add?
Yeah, and maybe part of that is that it depends what kind of gathering. So
yes. Right.
that really
Exactly.
skin to skin, that close contact is how it's transmitted very differently than COVID. So we use that framework, right, to do a little bit of those, the likelihood based on COVID, something that can be spread much more readily. Here again, is that skin-to-skin contact. So in a context where that is not expected, it's sort of relatively unlikely. And then all the more important to sort of evaluate if individuals have a new onset or rash that's unexplained and cover it when sort of in doubt, right? So those are all pieces that go together.
All right, perfect. So I've got a COVID one here that I'm actually going to let Massimo start with because it's about variants, and he's one of my experts about variants. So Addie Andy on Facebook says, is the new BA.5 variant more severe, and do vaccines not work on it? I'll let you start.
Yeah, so as a reminder, for COVID, we have seen SARS-CoV-2, the virus that causes COVID-19 illness, sort of evolve rapidly. And I remember sort of early phases, and then we sort of, Alpha came on the scene, and we've had this Greek alphabet sort of continuously sort of taking over. And it's always a balance in terms of what is advantageous for the virus to sort of continue to spread more efficiently. And so we have seen over time sort of that which is most transmissive ends up sort of displacing the past variant or subvariants. And so now for some time we've been in sort of this Omicron umbrella, but we have had multiple subvariants, and we're now in this BA.4. And similar to prior subvariants, we see sort of the great advantage that it spreads more rapidly. It sort of we haven't observed the same impact on sort of the severeness of illness, and sort of that's which you see and sort of what Dr. Awadi goes through, sort of the hospitalization and sort of the, even deaths, the eventual most severe outcome. So comparatively, I think the way it spreads more rapidly is the more sort of the prominent feature. It certainly, we do a lot of work to continue to monitor. Some of them may have some sort of can evade the immunity that we gain through vaccines, and sort of that's the reason why sort of we may see individuals reinfected, those who had it prior. But again, the impact of vaccine on infection, sort of, or this possibility for reinfection, different than the protection they do for sort of severe disease.
Yeah, I'd say one piece of really good news is that this original version of the vaccine that we've been using all along continues to be extraordinarily protective against those severe outcomes. What we've seen is as the virus keeps mutating so fast, if you remember, in the early days of being able to vaccinate, before we had all these variants, you had 90% protection from even getting infected. And as we've seen more and more, they get more and more contagious, more and more easy to spread, we also don't see as much of the protection against illness. We see more of these breakthroughs. But the severe illness protection remains good. My biggest worry are people who still have not had their initial vaccines. And that is, almost 23% of Chicagoans, now that it's open to everybody over the age of 6 months. Almost 1 in 4 Chicagoans still haven't had their initial COVID vaccine. And let me tell you, people who are trying to count on prior COVID infection, doesn't work for Omicron. It really doesn't. And even not for BA.4/5. So getting that initial those vaccines are important. We've given 5 million of them here, but that remains a high concern for me. And so, I hope, even though we're talking a lot about MPV today, continuing to encourage people to get those vaccines and to get a booster. Boosters have also been important, especially for older people with this BA.4/5 in terms of helping keep people out of the hospital. Okay. Dr. Cairns, one for you. Why is this called monkeypox?
So this is called monkeypox virus, actually not necessarily because it has anything to do with monkeys, but because it was first discovered in monkeys.
Right.
So we actually think that spread kind of initially occurs. So this virus itself tends to be endemic or kind of naturally occurring in certain areas of Central and West Africa. And the natural reservoir, so kind of where the virus lives, we think, although we don't know for sure, is most likely to be rodents. So some sort of rat or mouse or other type of rodent. But because it was actually discovered first in monkeys, that is where it got the name monkeypox virus. We have been starting to call it MPV just to reduce the association with monkeys because it's confusing, I think, a little bit.
It's not like people are exposed to monkeys.
Right,
That's
exactly.
not how this spreads. It's nothing like that.
And even though kind of what we've seen in the past is that the virus typically spread through contact with rodents, whether that's through kind of bushmeat or kind of game meat or contact with those animals. What we're seeing now is that spread really has kind of nothing to do with animals and is really occurring from one person to another in the US and in Europe as well.
All right. And just a quick maybe follow-up because people are interested. Is this the first time we've seen monkeypox here?
No, it's not actually. But up to this point, cases of MPV have largely been associated with either travel or with importation of animals from Africa. So for those of you who have been living in kind of Chicago or Illinois or even in kind of Wisconsin for the past 20 years or so, you might remember that there was actually a large outbreak of MPV that occurred in Illinois and Wisconsin in 2003, and that was associated with the importation of animals from Africa. In that case, primarily prairie dogs that were sold at things like swap meets, and then the contact with animals did wind up infecting, I think, about 40 to 50 different people, primarily in Illinois and Wisconsin. And then we also have seen, even as recent as last year, that there were, I believe, 2 different individuals who traveled to the United States from Africa who were infectious or contagious while they traveled. And so here in Chicago, for example, I was monitoring different individuals who had also traveled with a person who was sick. So they were on the same flight to make sure that they didn't develop any symptoms. Now, luckily they didn't. But we do occasionally see people develop this infection that have either traveled or had contact with animals. This is just a new version, what we're seeing right now.
Yeah, and how long have we known about MPV?
I believe it's about like 50, 60 years.
That's what I was going to say.
Exactly.
It's a long time,
Yeah.
many decades.
Yeah.
All right, good. Kelly Friel on Facebook. This one is about both MPV and COVID. She says, are you going to force monkeypox vaccines on employees like you did COVID? My answer to that is no. And specifically, where we're thinking about COVID vaccines and requiring it in employee settings, it is because there is significant risk of transmitting in general work settings. That is not what we see for MPV. Also, one other thing of note, you don't spread MPV based on everything we know now until you have a rash. So that's different from COVID. One of the biggest problems with COVID is for 2 days before you develop any symptoms, you can spread COVID. And so the combination of masks and vaccines that are necessary to control COVID are not necessary to control MPV because the risk factors are really quite different. And no, I do not at this point see any indication that we would have any requirement around MPV vaccines. And in fact, you saw there are more people, frankly, I would say in Chicago who might want an MPV vaccine than we have the capacity to give them right now. You want to add anything to that?
Nothing other than very separate, very different here, sort of for all the reasons you highlighted, and perhaps to really sort of drive home this component that it requires this close or intimate contact skin to skin. At present, and again, we have known of this virus for many decades at this point, not only is it not indicated for the general population, it's also not indicated for healthcare workers who may evaluate individuals who turn out to be infected with MPV. And that's really a reflection of the very different in the way they spread and sort of the impact they may have in a work setting.
Yeah, and so just like we do for lots of other infectious diseases, we have been following healthcare workers, who may have been doing the testing and the just to make sure that this isn't behaving in a different way or there's nothing more to be concerned about. And again, we're not seeing signs of major increased risk there or anything. And, it's a big nationwide and worldwide effort to really understand this. Okay. So a follow-up on COVID from Julie Bell on Facebook last week had asked about Moderna vaccines for 6 to 11-year-olds. So just remember that kids under 5 is where we had the most focus, where there were both Moderna and Pfizer approved. But later in the week, we had seen actual authorization for the Moderna vaccine for 6 to 11-year-olds, whereas previously only Pfizer had been available. And so, as I said last week, we would sort of look into it, and it was only a couple of days at that point since those vaccines had been authorized for that age group. And right now, if you go to vaccines.gov, you will see, you can put in your Chicago zip code or whatever, you will see that there are Moderna vaccines now available for 6 to 11-year-olds, in this area. So, Walgreens had them, for example. So go to vaccines.gov, put that in. And just as a reminder, 6 to 11-year-olds get half of an adult Moderna dose, and 12 to 17-year-olds actually get the same as an adult dose. So they were authorized by the FDA and the CDC just on June 24th, a few days after the authorization for the little ones. So Julie, if you've been checking since then, perhaps you've already found appointments for the 6 to 11-year-olds you were wondering about. But for everybody else, those are now available here in Chicago. Okay. All right, let's take another MPV. So a couple questions here about just vaccines. How do I get the vaccine? How much vaccine is there? What's happening with vaccine availability in Chicago?
Sure, I can start and we can add from there. So again, vaccine is sort of at present in limited amounts. And so we are always prioritizing those who can benefit most, and that remains those who have been exposed or those who are likely to be exposed. And so in this initial phase, this is sort of work that we have started as soon as we had any cases here in Chicago and Illinois. And then in addition to that, there's now a national strategy to both support the work sort of aligned with the strategy we've taken to support that work, and to manufacture and distribute much more vaccine, so that not only more jurisdictions, other places that are experiencing something similar to Chicago can also be supported through this similar work, and that as needed, we'll be able to expand the eligibility and the administration of vaccine. But again, always targeted to those who can benefit most based on the fact that it really, both the way it spreads, et cetera. And so at present, I can quantify this a bit to give you a sense. Mm-hmm. In advance of this national strategy even being deployed in Chicago, we have ordered, received, and deployed to clinical settings about 1,200 vaccines, again, for those who had been exposed, et cetera. And then with this initial allocation, we're one of the settings that's prioritized for a little bit of a more robust allocation, because much like in California and in New York, we're experiencing a little more cases than other settings in New York. We have received about 3,200 vaccines. And again, this is only the first phase, and it reflects that which was on the shelf and got immediately deployed. We expect more to come in coming weeks, and certainly much more as more doses become filled and arrive in the US, as well as more gets manufactured. So the plan is to have upwards of just about over 1 million doses in coming weeks and months. So we'll be in a position to sort of support this, certainly here in Chicago and then across the country as it presents.
And then that 1.2 million doses, unfortunately, is nationally, not just in Chicago, so we'll only be getting a fraction of that. And I think one thing to highlight here is that this is very similar to the initial distribution of COVID vaccines, where you saw kind of, if you remember, the phase 1A and then 1B and 1C. So those who were really at highest risk, so for COVID, that was, I think, those over 65 or 70, I believe, if I'm remembering right, as well as healthcare workers were prioritized. And so what we're doing for MPV is similar in that we're prioritizing those who really are truly at highest risk. So those who have either been exposed or are likely to be exposed, as was just said. And I think if you consider yourself in one of those risk categories where you're concerned, then one of the first steps is to talk with your healthcare provider. Unfortunately, we don't have enough vaccine for everybody who meets those criteria right now, but we are trying to get that vaccine out as soon as we can.
Yeah, and I would just add a little more context to that. So because MPV is really rare, you heard us say we see a case a year, maybe, really, really unusual. It's not like there's lots and lots of this vaccine just sitting on the shelf. Your doctor does not just have it in their office. Your pharmacist does not just have it on the shelf. And so the U.S. was keeping in what's called the strategic national stockpile. They will keep some vaccine in case of outbreaks, in case of need. And so they have already, these initial doses that we got as we started to see cases were what were in that stockpile from the beginning. And the federal government, when there is not a lot of these products needed, really will be the purchaser here. And so they have already put in additional orders. There's more that are coming from Europe. And so they've been able to scale for us in an approximate kind of way what the ramp looks like for vaccines. But we don't have additional just vaccine at the health department. Nobody does in the country. It really is around what stockpile we have, and then there's been a big ramp up of vaccine creation and some of the filling and other things that have to happen, just so we do our best to try to stay ahead of this. So we've been advocating, and so have a number of the especially the LGBTQ plus sort of advocacy organizations, just to make sure vaccine is getting where it is most needed. And we want to make sure every dose, just like at the beginning of COVID, is going where it is needed most. And as more vaccine becomes available and we see what happens sort of with this outbreak, we will of course be working to make it available for more people. Okay. Michael Z. Robin on Twitter says, why did Chicago, this is back to COVID, why did Chicago lift mask requirements on CTA? Every bus I've been in the past week has been 90% unmasked. How are disabled and immunocompromised people supposed to live in this city? I hear you on this, Michael. I actually took a CTA bus this morning and everybody on my bus had a mask on, but that was during rush hour. And I have noticed that during rush hour on both the buses and on the L, both parts of the CTA, I've noticed much better masking. I think those tend to be Chicagoans who are going to and from work and want to be careful. I have seen less masking, though, I agree with you, especially outside of rush hour settings. Those may be tourists, other people in. And what I can say is that Chicago didn't lift the mask requirement on CTA. Actually, it was a federal requirement to have masks required on public transportation of all kinds. So buses and trains and airplanes. And this was challenged in court, et cetera. And then at the federal level, they did make a decision to lift that as a requirement. We still absolutely recommend and ask Chicagoans to mask. And you hear, to Michael's question here, that when you put a mask on, it's a little bit about you. It's mostly about everybody else because you can spread COVID. Like I said before, you can spread it for 2 days before you even have symptoms. And where there are people who are immunocompromised or disabled, they need to be able to take the bus. And especially while we're still at a high level of COVID, it is the kind thing to do to keep that mask on. So I know CTA continues to encourage it, but there is not a legal requirement here or anywhere in the country at this time. I would say, similar to what you've heard me say for other kind of questions around requirements, where the city would consider putting in or reinstating additional requirements, whether that's a mask requirement or potentially a vaccine requirement for high-risk settings. That would be, for the most part, if we started to see our health system get threatened. And we cannot run that risk as a society. And just like we did at the beginning of Omicron, we had more people hospitalized in Chicago than at any point. Our hospitals were overrun. That's when we put more of this back in place, and that's what we would do again. But in the meantime, listen to Michael there, put your mask on, please, especially on transit. It's one of the things that people need to be able to take to get around this city. And you can try to distance, but it really does help. Okay. So there's a follow-up on MPV here from Kelly Friel on Facebook. She says, so you're saying the monkeypox is coming from Africa?
Oh, that's a great question, and thank you for letting me clarify. So originally, what we had seen is that MPV primarily was associated with travel to Africa or animals that were in Africa kind of being sent here. But what we've seen now is that it really has spread outside of Africa. And we don't know kind of how this originally got into other populations. We're just not quite sure about that yet. But right now, for example, of those in Chicago who have MPV infection, we have not seen any association with travel to Africa or with contact with animals from Africa.
All right. Anything to add?
Yeah, just maybe that, again, all outbreaks start somewhere, and sort of although we don't have this sort of the origin all the way back, that's what we're observing now. And to that point, we're seeing at present amongst these closed social networks as it spreads sort of with close contact in the MSM community. But again, there's nothing inherent to the virus, to the biology of the virus, that doesn't discriminate based on sex, gender, or sexual orientation. And sort of that is why at present we're allocating all the resources to kind of protect and control where we're observing the virus, but there's certainly nothing inherent that associates the virus with a community or that we can certainly see it sort of spread to others.
All right, sounds good. We're getting close to time, so I want to get through a few of these COVID questions, and then we'll probably wrap up at the end, maybe with one more MPV. So Welly Michael on Facebook is asking, how many children in Chicago are currently in the hospital due to COVID? I'm going to answer that actually right off our dashboard. Are we able to bring the dashboard back up here, maybe? And I'll show you just how we're going to look at that. So if you want to know more about cases in Chicago, hospitalizations, deaths, anyways, you click right here on this cases. And then down at the bottom, if you want to know by age, gender, race, ethnicity, I'm going to click on age. And right here, this is going to show you down at the bottom in the middle, current daily averages by age. So right now, among 0 to 17-year-olds, we're averaging 88 Chicagoans between 0 and 17 getting diagnosed with COVID every day, and between 1 and 2 being hospitalized, 1.4 on average per day. And you get a sense that that is, people over 80, we've got 5 being hospitalized every day. So the risk, as always, thankfully, is lower, but it is not zero for hospitalizations in kids. And if you want to get the specific numbers, if you click over here with hospitalizations, and let's say if we just look just in kind of the last few months here, you can see that literally on sort of a daily basis here, June 21, there were 3 people between 0 and 17 hospitalized. So you can explore the specifics, but basically we have between 1 and 2 children a day being hospitalized with COVID-19 right now. And that's how you can, the reason I went to show you this is just to show, if you want to look at deaths, whatever you want to look at, it's all available and up to date on the dashboard. Okay, we can come back off the thing. Thank you. Tina Valdez Perez on Facebook. How long do you have to wait for a second booster if you tested positive? Good question. You do not have to wait for a first booster or a second booster if you test positive. We generally have used as a general rule that in the first 3 months or so following being infected with COVID, you are less likely to be reinfected with COVID. That said, with Omicron, and particularly BA.4/5, we are seeing more people get reinfected, even within that 3-month time period. And so I would, what I've told my friends and family, frankly, is just just not to wait. I have encouraged people, you've got to be out of the 10 days. You've got to not have symptoms anymore and be feeling better. But if you are eligible for a second booster, that means you're over 50 or you have, more serious underlying conditions. I would recommend just going ahead and getting that booster because that's going to get you extra protection, especially against more severe illness. And then again, in the fall, we're heading for probably an updated vaccine for everybody. In the meantime, though, getting your booster now helps reduce the risk of those serious outcomes. Anything you want to add there?
That's great.
Yeah.
Okay. All right. Let's also get a quick one in here from. I saw a good one. Let me just. Rosa Guadalupe Urbano on Facebook says, do I have to COVID test coming back from Mexico? Good question. The answer now is no. As of June 12th, so just a couple of weeks ago, CDC no longer requires air passengers who are coming in from a foreign country to show a negative test. You used to have to show a negative test or documentation of recovery before boarding a flight. However, the recommendation, very strong recommendation, all travelers, ensure you are up to date with your vaccine, including boosters, before you travel. You do not want to get COVID while you're traveling. I get emails from people, and it can be a lot harder to access the treatments that are available if you're out of the country. So you really want to be extra careful. It can ruin your vacation, right? So make sure, you want to do everything you can to protect yourself. Be up to date, including your boosters. Everybody who's traveling, full stop. I would travel with a home COVID test. I always do, no matter where I'm traveling. Just because if you're getting any symptoms, you want to be able to test and isolate quickly, and then bring a mask. You may still have individual sort of airports or transit or businesses that will require masks. In Mexico, masks are required practically everywhere still. It's right. Pretty remarkable. But no matter where you're traveling, wear that mask, be careful. But no, you are no longer required from Mexico or any other country to have a COVID test. Anything to add? Or?
Yeah, and that is all about re-entering the U.S.
Right.
When you travel abroad, is then checking with the individual country, because they each may have their own requirements around that.
All right, we're just about at time. I'm going to take one more COVID and then as a last question about MPV. So Carbo425 on Twitter says, is there an off-ramp for the mandatory 5-day isolation period for COVID? I'm a teacher and parent of a young child. It's terribly disruptive to daily life. What is the timeline for treating COVID like other viruses? Stay home if you're sick, return when fever-free for 24 hours. Yeah, good question. Right now, there is not an off-ramp for that 5-day isolation period because COVID remains so contagious, so infectious. And in fact, remember, it's 5 days of isolation, but then days 6 through 10, you have to wear a mask if you're out and about because we are seeing people continue to be able to transmit in that 6 to 10 day period. And in fact, the Omicron BA.4/5, sort of anecdotally, we're seeing people sort of continue to test positive for longer. You don't have to have a negative test as a reminder, but it does look like we're seeing some more prolonged illness. So right now there is no off-ramp for that isolation period because we still have lots of people getting hospitalized and dying with COVID. This is not the same as flu. I wish it were in terms of what those outcomes look like. And so while, you yourself, it sounds like you have young children, you're probably not at high risk for that severe outcome. If you're not isolating and you are spreading COVID, which is very easy to do, even if you're obviously not trying to, you are still putting people at, pretty significant risk. And, almost a quarter of Chicagoans aren't vaccinated. And although that's an individual level decision, even people who are vaccinated with Omicron, we can see more breakthrough infections. So I would say, for COVID is not unusual in this sense, I will just say. There are required isolation periods if you get the measles, if you get, there's a lot of differences in terms of what virus you get. How infectious, how contagious is it? How dangerous is it if others get it? And so, although you're saying, where do we treat it like other viruses? Stay home. There are other viruses that have other guidance, and at the moment, COVID continues to have that other guidance. All right, so I think as our last question, because we're at time here, let's just maybe do a quick summary. What are the most important things I need to know about monkeypox virus right now, MPV virus right now, and is this the next COVID pandemic?
Well, good news, it does not seem to be the next COVID pandemic for a variety of reasons, but I think it really does help, again, that this is not a new virus, that we have treatment and we have vaccine available. I think in my mind, kind of some of the most important things to know, if you're sick, stay home, get checked out by a healthcare provider. That being said, the risk to the general public is really low. But if you are at high risk and you do, especially if you're not feeling well or if you have a new or unexplained rash, then you really should stay home and get yourself checked out.
Yeah, and maybe, we're highlighting the ways in which this is different, and I guess in some ways, and sort of to engage this, in which is the same, is to really get the information from trusted sources.
Yeah.
As we learn more, the guidance will be able to provide additional guidance, additional opportunities. And then engaging with the clinical provider, and if you don't have one, there are some resources to connect to one and sort of follow their advice. And then last, I'd say, in a way that it's similar, is this sort of adherence to that which we know it works. And so for a virus that it isn't spread in advance of symptoms, like MPV, that requires sort of that lesion, it's particularly important to adhere to the isolation for those who are affected, and then for those who are exposed, to symptom monitor, get the vaccine uptake. These are, in the context of a virus that doesn't spread in advance of symptoms, incredibly powerful to contain the outbreak. So following the advice of the experts, getting sort of trusted sources to get that information is possibly a key component that is common to many things.
Absolutely. Watch for a rash, see your doctor if you have a rash, and if you're higher risk, we can do something about it. It's different than COVID was. Okay. We are at time. Sharon Balco, I see, put in a quick question. What's the percentage of under 5 children in Chicago that have been COVID vaccinated? Our data team is going to be updating our website over the next, few days to week to make sure that group is also reflected. I can tell you that in the first week or so, it was less than 10%. So we saw thousands of children certainly get it, but we've got around 260,000 Chicagoans in that under 5 group. And so we'll bring some more data on that, but it will be part of our dashboard probably before we're on next week. So thank you. If we didn't get to your question, we will address it next week. I will be back at our regular time next Tuesday, July 11th. At 11 a.m. And thank you for joining. Again, we were joined today. This is Dr. Jana Cairns, one of our medical directors in the Disease Control Bureau, and Massimo Pacilli, Deputy Commissioner in the Disease Control Bureau. They both have been at the health department for a number of years and are total rock stars in terms of getting things done. So when I'm answering questions, quite often I'm dependent on the information that they and their teams are really sharing with me. So thank you for your time, and to everybody and partners too who have been working on making sure the right information gets out about MPV, that people who are at higher risk are the ones being prioritized, for vaccine. If you are in contact with someone who has monkeypox, we can get you a vaccine right away. And if you do get monkeypox and you're at risk for more severe illness, we can get you treatment right away. But it means connecting to your healthcare provider. We'll be back next Tuesday at 11 a.m. And we are going to, moving forward, probably be doing a little bit of a mix of sort of COVID and one other topic sort of each week. So let us know if there are topics you're particularly interested in having us address. I know sort of substance use and violence prevention are high on the list to come, but let us know if there's other topics that you'd like us to focus a little bit on, because I think it's a good opportunity to both keep up to date on COVID as well as a lot of the other things that we actually spend most of our time at the health department working on. Please be safe, and we will see you hopefully next week. Bye-bye.